we have a small panel discussion now. Later we will go for lunch.
So actually the live surgery is got over well ahead in time. We were planning for another one periodic dice, but due to some other reasons we were not able to continue because of time constraint. So time between us and lunch is another 20 minutes. So I thought we will fill up the panel discussions. Around actually four of them should be panelists. Dr. Srinivas Kishore has got a flight to catch at 4 p.m. So Dr. Sankesh and Dr. Srinivas Kishore is already left. So this session is mainly for the postgraduates and for the ENT surgeons who are having a plan to choose sleep medicine or sleep surgery. So these were the questions which lingered in my mind 2 years before. So I thought this should be an eye opener for many, and we have got two great personalities who can answer anything, especially in sleep. So FAQs of your budding surgeon. Sir, Dr. Vijaya, sir. You are the best person. I think yesterday itself, Professor Mohan Kameshwaran has explained in detail. To long story short, please, what's your opinion regarding what the scope of sleep surgery, sir?
There is a lot and a lot. You have seen everyone's slide was showing billion and million of people is suffering from this disorder, and definitely a lot of patients are there. Second thing is you can understand how many conferences and programs are happening in this field, and that itself shows how much interest is being created and awareness are being created. So definitely, no doubt, there is a lot of scope, and it is not a difficult scenario as a ET surgeon to manage these cases. The only thing is you have to understand the concept and manage these patients.
Whenever I get an opportunity to present in front of other specialties or MBBS students or postgraduates, the only thing which I'm constantly saying nowadays is at least ensure from 5 years to 7 years or 10 years from now, definitely in the normal history taking, just like how you are going to say the history of diabetes or hypertension, definitely we'll be asking the history of OSA because there is a separate book on that where the effects of OSA on multi systems of the body, and you would be surprised that even in orthopedics to dermatology, in every aspect, there's been research and going on regarding the physiological effects and pathophysiological effects of OSA on the ecosystem system.
And one more point to add, nowadays it's a routine top and questionnaire in their pre-anesthetic checkup.
Yes.
So they have that stop and questionnaire and they assess the chance of OSA in those patients.
Yes, sir. Question also is directed to you, sir. So, how can one train post MS or DB or DLO in order to become a sleep surgeon?
Basic idea about adenotonsillectomy, and I'm sure everyone of the name what you listed will be having that experience. And that is the basic of any surgical procedure in OSA. And they should be having should have attended a couple of training programs and conferences, and then they should be on regular touch with the current updates, and attending the conferences is the most important, I would say. And then they have to form a multidisciplinary team to manage this patient, not as single alone. They should get pedodontist, pediatric dentist, patient management surgeon, and myofunctional therapist. So when you form a group, so that will stabilize your foot in this area in your place.
Yes, so I was more particularly asking about is there any training programs? Or?
Yes, we have a training program under the banner of Indian Association of Surgeons for Sleep Apnea, ISSA. CTP program is the certified training program, 2 months program, certified training program, and you have to keep updating yourself. That's what I'm repeating.
So, because one of the commonest challenges in EEP field is there is no proper postdoctoral fellowship programs here. So, definitely we'll be having a doubt of which one to follow. And definitely, like everyone, I think will accept that most of the fellowship programs available, there will be the lack of stipend, monthly revise, it will be a challenge for a travel man, especially for those like me who got married earlier during my postgraduate days. Immediately post graduation to go for spend another 2 years under various training for monetary issues will be an issue. So in that case, this one that was one of the reasons why I took this program, because it was 2 months program, so I could afford at least somehow I can manage. So this certificate writing program is one of the accredited programs for sleep studies.
That's what I said. Minimum 2 years experience will help the candidate to easily get acclimated to this training program. If you're going to be very fresh from start, you have to do means within 2 months it will be just over and you won't be knowing in detail. To understand within the 2 months period, and as he rightly said, we have chosen 2 months that so that the candidate also will not find it very difficult to do the program by doing 6 months or 1 year. Within the 2 months, we are not going to learn everything, but that will give an idea about OSA. And as I told earlier, we have to be on regular touch, and we have a group of people that we keep discussing and about OSA in our forum.
So the next question is to Professor Anthony. So if a postgraduate wants to or is interested in sleep medicine, so what kind of things should be done during postgraduate?
See, actually, EAP is a very large field, particularly for somebody who is learning in a bigger institutions, and the number of postgraduates is around very high. So when you are doing your second year, you got to decide that when you are doing your MBBS, you prefer your area of interest. Similarly, you got to prefer your area of interest. You see the conferences now. Today there was skull-base surgery, head surgery, autology, cochlear implant programs are all famous some years back. Today's most happening thing is one is the sleep, other one is the laryngology. So you decide what you want. It's like you can go for something what is proven already as the best one, or if you are selecting your field, then you got to show your interest as Vijay Krishnan says, even if you go for a 2 months program, you will get chances only when you are interested. So you show interest in the sleep and catch hold of sleep surgeon in your institute, and you follow what we did. What we did in Stanley is we used to have a head and neck team. We used to have a skull-base team, and we used to have a sleep team. So this was happening in 2014, 15, 16 those days. The people who are all on the sleep team were all Shankar, Ganesh, Prabhu, and all these people were all on the team. And when you see the patient who is having slow image, we will give it to them. And they work up the case, they know what to do. And once they become seniors, they will catch hold of somebody and put it into the way, and they will come on the same thing. The same thing is true for skull base. You every 15 days we will have one pituitary, one cranio, one primal. But the thing is, the person who is there in the team, they used to take care of all the follow-up and other things. But everybody is seeing everything, nobody will be seeing anything, and nobody will get interested in anything. That's an issue.
So the reason why I asked this question is, like you said, only our mind knows only what the eye sees. So during my first year post graduation, Stanley's first sleep lab was introduced. So all we gave a press interview. He spoke, and immediately all of the story patients came in bulk. And what Professor Anthony did was he gave a pediatric OSA to one of the seniors and adult OSA to another senior. So being the first year PT, I was the one who was setting up the sleep study, getting the sleep report. So from that point so imagine first aid PT, say looking, seeing lights for the first time in the OT. The patient is snoring, you're putting endoscope, something is happening. So those were the days got this sparked some interest in OSA, even though he asked me to go into skull base. My liking was, this was more attractive for me those days. So yes. So second, so fourth question, so armamentarium for a sleep surgeon. So if ENT surgeon is planning to become or take up sleep surgeon, is there any particular instruments or like what are you should be having in this sleep?
See, this from your cold sleep instrument to all the tools are all important for sleep. A tool with this usage will make you a more accomplished surgeon. So commonly used tool is coagulation, but the problem with coagulation is not being precise. For example, you want to split uvula, you need something which is precise, so you go for radio frequency. And if you want to debulk, bloodless coagulation is better tool. So radio frequency, coagulator, and then even your bipolar artery and your cold state instruments. And for the assessment, you need a good 2.3 or 4 mm scopes, flexible scopes. Nowadays, there are cheaper scopes that come. As usual, they come for one-time usage, but we use it for multiple times. Another thing is that sleep study you have in an institution, best this thing is level 1 study. But level 3 study is for home thing. But if you are doing a private practice and you want to have when you want to start a sleep program, at least you need a level 2 to sleep, where it will cost you between 3 to 4 lakh rupees. And even if you do a good diagnostic tool charging 600 rupees per month, you will earn it soon. But it will give you a lot of cases. But studying sleep study, you can't see just the results and go. You got to know how to read the sleep study. Every AHA in every level, what is an REM sleep, at the REM sleep, what is the level? Now, all these things you need to pick up. You got to go for a sleep study training to know all these.
So, variations regarding the sleep study.
Yeah. So the first and foremost is, I would say, sleep lab. So level 2 or level 3. So level 2, as you rightly said, it will be in the range of 3 to 4 lakhs or maybe more than that also.
6 to 7 lakhs.
6 months. But level 3 itself is sufficient to start with, which may cost around 1 lakh. But you will get that money in few months if you really promote yourself as sleep surgeon and do a proper study and reporting. And the second part is you yourself should be able to score the sleep study report. You may have to spend little time to learn about it, but that will give you an idea how the technician will do, so that you will be able to pick up artifacts, or if he has done any mistakes in that report, we will be able to pick it up. It's like we ourselves should know how to do audiometry. So similarly, you should learn about scoring and reading the report. Don't just see AHA value, low saturation value like that. Go through the entire report from what date it was done, how many hours it has been done, whether they have properly recorded, how many artifacts are there in the program. So everything you should see. If you do and see about 50 patients of sleep studies you have done, then you may get 1 or 2 patients per surgery. Though we call it as sleep surgeon, you will be managing mostly with CPAP and non-surgical.
The question is reserved for the later slide, sir. So yes, as I said that it's always will be a dilemma to invest on any equipment, especially so I was in a dilemma whether to get a sleep study or not. Definitely level 2 was little out of budget. So level 3, yes, I thought my initial target was at least 2 months, 2 patients come in a month for sleep study, it will be okay. But to my surprise, people are ready to get it tested. Whether they want to go for a CPAP or surgery and whether they are willing for treatment is secondary. But this, as I said in yesterday's lecture, the social stigma is increasing. So definitely people are interested, I mean people are willing to get it tested. So it's better to at least have a level 3 sleep study will be better.
One more point is there will be a lot of people, they will say we will do a sleep study and we will give you the report. That is okay if you can't invest on that sleep lab, but otherwise if you invest, then you will get a label that you are a sleep surgeon and you have a snoring clinic. So that adds that, as you rightly said, a lot of people will come for that you have a snoring clinic or sleep clinic and sleep clinic.
So then the most favorite question, coagulation anatomy versus microdebridectomy. I think it was already discussed during the Vijaya surgery. Any points to be added, sir?
I think it was clearly discussed.
Yes. So regarding the palate surgery age criteria. So is there any age criteria to do the palate surgery?
See, I keep in mind more than 30.
30 years.
30 and within 60. 30 to 60 is, I think, can be done. And it's not possible more than 60 or less than 30 or 20 to 30 or even pediatric. But I will try my maximum to avoid cutting and uvula and restructuring, as that's a period where we can be able to sort it out without surgery. If not possible, I have.
How about between the 20 to 30 age?
Yes, for 20 to 30 group, maximum I will try with other modalities, weight reduction, exercise, and unless there is a strong anatomical obstruction like tonsil, huge tonsil. In that scenario also, I have done just tonsillectomy and abdominoplasty, and everything with an explanation to the patient that we will re-evaluate after 3 months or 6 months, and if it's still persisting, then I will be doing a calculation.
So again, one of the favorite questions, even most of my friends, other specialties, everyone, whenever they come across a OSA patient who is obese, so immediately they will say, go weight, do weight loss and then come. So how far it is true, sir?
It is very, very difficult for an OSA patient to, I'm sure everyone will agree with that. See, it is a vicious cycle. So OSA causes obesity, obesity causes OSA, and that unless you reduce the inflammatory process, it is very difficult to do an exercise and weight reduction and diet restriction, whatever they may do. So it cut that vicious cycle at one part, either by surgery or CPAP. The first preference is definitely CPAP or maybe BiPAP, and then put them on a weight reduction program. And then now the recent option is tirzepatide, which we are trying and we are looking for the result in OSA patients. So because tirzepatide, once you stop again, they may put on weight, but when they are in OSA patient, how it's going to, it's still under study in our center, but we will come up with a result in a year.
So the point is, okay, the next question the patient will ask is how much weight should I reduce? So if at all you want to have a significant change in the symptoms or the value, at least 15 to 20% of the existing weight is recommended to at least see some effects. And especially one more point we add as well, like surgery for obesity patient, any or especially for sleep surgery patient, any cutoff you have for BMI?
BMI, as I told you yesterday, maximum I will try to avoid more than 30. 30 BMI. So I will try my best to avoid OSA surgery and will put them on CPAP and other modalities. If it is not possible or they couldn't use CPAP, will do interventional.
Actually, reducing weight in the OSA is very difficult. So, but the patient will reduce weight, you can go for another vicious cycle. You operate on a patient and don't make the patient very comfortable. Balance the minimum painkillers. He will not take food for 15-20 days. he will know what is the advantage of reducing the weight. See, the problem is reducing weight is one thing, and maintaining that weight is another thing. You can reduce 4 kg easily. Within 3-4 days, you will gain that 4 kg. So other problem is that generalized inflammation in the body. Once you do the surgery and patient is not taking the normal food for about 15 days, they will reduce the weight. And particularly these youngsters who are below 40 years, they will know the advantage of this, and after that they will see to that they don't put on this. Okay, so then we go for the positive circle where there will be a reduction in OSA, then they will see to that weight reduces more and more reduction in OSA. Second thing is the absolute cutoff is 35 to 38 BMI. Above that, you will send the patient for a bariatric surgery, then train them straight away with the OSA surgeries because difficult, need more anesthesia related problems, technically surgical related problems, more opening will be there, you need larger tanks, it takes more time and more problems with the post-operation. So reduce the BMI, do some bariatric surgery. Once they come to the age of around 10 to 33, then you do the surgery, you give the good results. If you are good enough, even for a CPAP, that is better. Yes.
So, most important question: how to counsel and OSA patients? Dr. Vijaya. Regarding all forms of treatment.
So OSA patient is sitting in front of you, so we categorize them. So when after the report, everything you have done, and mentally you will be prepared whether this patient needs surgery or we are going to send them with CPAP. So I'm talking in case if the patient is eligible for surgery and you are going to counsel the patient as if you are going to convince them for surgery, means that you have to speak in that aspect that you have different options, you have a problem. First explain and make him understand. We have separate videos for that. I will play that video, what is happening in the sleep, what is happening to the airway. That visual videos will make them to understand easier, number one. Two, if you have done sleep study, show them how many times these sessions happen. And if you show the hypnogram, that is the what happened during the entire sleep period, how many times this saturation is happening, so that also will be impressive for the patient to understand what is happening. And third thing, if you have done sleep endoscopy, show the video and explain them how you are getting choked and snoring is happening. So that also will make the patient to understand where the problem. Then once he understood the problem and already he knows what are the problems already happening for him, like snoring, mouth breathing, sleepiness, etc. That part explanation is easier. Third part is treatment aspect. So if his BMI is high, make him to understand that weight reduction is foremost and he has to do exercise and weight reduction. Second thing, on management aspect, you have option of both surgery and CPAP. So then I will tell him what are the plus of CPAP, what are the plus of surgery. If he is wearing a glass spectacle or a hearing aid, I will explain him easily, and specs is the one which people can easily understand. So it is like wearing a specs. If you wear the specs, you will be able to clearly see, and if you remove it, if you forgot it, that day you will be finding it difficult to look at your book. So similarly, if you wear the CPAP daily, you will be comfortably sleeping, and if you forgot it one day, even if you forgot it, that day you will be snoring. So that message I will put it across, that you have to use the CPAP daily. So, and if you are given an option of doing a surgery on your IBD for refractory index, there is 90% chance that it will become normal. Sometimes you may have to wear the glass even after the surgery, even after cataract surgery. So sometimes you may have to wear the glass. So that will make him understand that okay, surgery is not the endpoint and it's not 100%, and it will definitely reduce the disease burden and it will not completely solve the problem. So even after surgery, you may have to use CPAP. So that message also I have to deliver. So that's how I counsel, and I leave the patient to take the decision and come back. Even I give them 1 or 2 days. And if the patient is slightly towards non-surgical, I will even ask them to use CPAP for 3 to 5 nights and try yourself and see how you feel and how the CPAP will be. And if you are comfortable with that, use it. If you are not comfortable, come back.
Yes. So I give an example of two things. One regulatory sorry, sir.
The thing is, these are all for the people who are coming to it. But more than us, the most voracious patient centers are thoracic medicine people and the neurologists. They tell the patient for sleep, put a CPAP, send them off without even looking into the patient. So most of these patients don't use CPAP. Those patients are the main bulk of patients who search for ENT sessions because they don't want CPAP and they somehow want to get rid of the disease. So these people, the expectations will be more and but when the patient comes directly to you for a snoring problem, he thinks you will give him some few tablets and he will become alright. So making them coming out of that mindset is the first thing. Second thing is to do a surgery for them is something. And then there are people who come who have got a very bad OSA and they have already had problems, like they have had a cardiac event, they have massive accidents and things like that. Those people we usually don't go for surgery. What we advise them is only CPAP. And they will accept because they have no.
So they told about the treatment options. So even to make the patient get treated or consider treatment itself will be a challenge because they all think like snoring is not a disease. So my favorite analogy is I give an example of cricket, especially fast bowlers. So I'll just tell them, have you ever heard of anyone having a shoulder surgery in your friends or relative circle? But you see, Bumrah or Shami, they'll be having a shoulder surgery because they are using this organ again and again. So the same way, if your heart is getting stressed again and again every night during sleep, definitely you will be ending up in a cardiovascular problem much earlier than others. So I think I was actually want to have one lecture regarding this by Vijaya sir. Of course, maybe next time. So single stage, multi-level with stage, just a few words.
Again, this choosing multi-level, single stage or stage is depends upon patient's factor and surgeon's factor. So patient factor, if the patient is having severe multi-level obstruction, and if you think you can't manage it single stage, better to do multi-stage and make the patient understand. And patient should be you should be convinced that patient will be in the regular follow-up with you so that you can stage it. If you think the patient will not come back or he is in abroad or he is working abroad, he comes once in a year or something, then it may not be completely solved the problem. And if you are doing multiple stages in this multi-level obstruction, the patient should understand or convinced that he may have to use CPAP in between period. Because he should not think that once surgery is done, everything is done. And especially when you are doing a cardiac surgery or nasal surgery, the patient's well-being will maybe better, snoring may be reduced, but he may be still snoring. So that second thing is about the morbidity, pain, everything, maybe little more than what the essential level procedure will be. So that also patient should be able to accept it. Nasal block, throat pain, everything together. Maybe the patient, if you think the patient will not tolerate, better to stage it. Third thing about the surgeon's factor is his comfort. At least he should have done few cases of single level procedures so that he'll be confident that he'll be able to manage the complications, not the surgery. Surgery he will finish But the complication, if there is any bleeding, anything happens in the post-op, he should be able to manage it. There is definitely different levels or ways that complications can occur in these patients. Managing also a little different when you have done purely tongue surgery or you have combined with cardiac surgery and tongue surgery and nasal surgery. You may not even know sometimes where the bleeding is coming from the nose or in the tongue case. Only the blood will be there in the mouth. So that surgeon's factor is also very important. And most important, surgery treatments, anesthetist comes with you. So they should also be prepared to manage these patients, what drugs can be given, not be given, and how to intubate in typical scenarios with a lot of blood in the oral cavity. Everything happens in few seconds to minutes. So your entire team has to be able to manage post-op complications rather than, I would say, intra-op difficulties.
So again, role of an ENT surgeon in CPAP non-compliant. As sir said, only 30 to 40% of the OAC patients offered CPAP, they are compliant. So 60% non-compliant is one of the reasons why other specialties also started to have role in sleep medicine. So role of an ENT surgeon in CPAP non-compliance.
So the role comes when the pressure is higher. For that, you have to see the CPAP usage report. So in that, you will be able to see how much is the average pressure, how much is the maximum pressure going, and the patient is not able to tolerate CPAP. In that scenario only, you have a role. Sometimes the patient is not comfortable to use CPAP, not able to carry everywhere. That is different scenario. In this scenario, when the pressure is very high, yes, definitely we can do nasal procedures and palatal procedures to reduce the obstruction and resistance so that the patient will be comfortable to use CPAP post-operatively.
So that's what, so this is how, like, whenever a CPAP topic is there, whether ENT can, yes. So are ENT surgeons the only one who can manage OSA? No, of course, the multidisciplinary approach. Is surgery is the only choice? Obviously, no. Can ENT surgeon increase the CPAP compliance? Yes, of course, addressing any case construction or any block. But is ENT consultation is needed in case of CPAP non-compliance? Definitely yes. Ideally, before CPAP advice, ENT consultation is advised, but it's not mandatory. But whenever there is a CPAP non-compliance or failure, ENT consultation is the one.
One of the commonest reasons for CPAP non-compliance is high pressure and discomfort.
Yes, sir.
So that can be easily sorted out with our surgery.
Our routine diagnosis.
Simple adenoids and tonsils may be huge even in elderly 45-50-year-old. So if you remove that, the pressure will 50% the pressure will come down.
So this is one of the common doubts. Most of the times, I think this was again addressed yesterday. So usually before going for any dental procedures, they will be sending for ENT referral to do obstruction. So there is a grade for advance, okay, but if there is a grade 2 to the advance, that will be mouth breathing. So how should we? What is the ENT role in this?
Exactly. I have my friend here, Roshan, who is having a talk later. This is another scenario where dilemma whether to do surgery, whether it will improve. Yes, definitely. Grade 2 is okay, but grade 3, you remove it, it will every millimeter. If you increase the space, the pediatric age group, they will be able to breathe much better. And I will always tell the patient that just by removing adenoids and tonsils, the child is not going to close the mouth and breathe through the nose. And definitely you will need a post-op evaluation on dental aspect so that they will take care of the myofunction therapy and dental.
So post-op management program or post-op management for a multi-level surgery.
The surgery, what we do depends upon where you do. You will be doing it in a small hospital or your private practice, where people are not used to do OSA surgery, you want to be doubly trained. If you are doing it in a center, they do a lot of sleep surgery, or they have a better post-op ICUs and you can take little bit. Basically, what you should immediate post-op and up to 1 hour is very important. 1 day is very important. So once you do a sleep surgery, even though you use good instruments, there can be bleeding or edema and the airway obstruction again. So you come out of that thing first. Then post-op management is mainly antibiotic, maintaining airway and things like that. And the first 6 hours you got to be very careful. 24 hours you got to be very careful for the airway and we give take care of the bleeding.
Because one of the common things which I come across is nowadays with the advent of advisory workshops and YouTube videos. So everyone is attempting parallel procedure. So just before the day of surgery, they asked me like what are the post-op things should be done. So these are the basic things I follow. So at least 4 hours of ICU observation. So once the ICU team is confident that the patient is stable, then they will be shifted to ward, proper position, and O2 continuous office for the first to last to 24 hours is recommended. And definitely in my setup, I use only single stage multiple surgery, so IV antibiotics for 5 to 7 days and give adequate anesthesia and post as we said, liquid diet for 7 to 10 days. That itself will cause severe muscle wasting. So we can advise protein supplements as well. I personally advise whey proteins. So even though that's many people will have something else against that, and try taking antidepressants and more like it. So one of the main reason is if OS is concerned, this age will not be a criteria for our evaluation because for my first patient, single stage multi-level, 3 weeks post-op, he developed dyspnea on exertion. So on evaluation, he said he has a grade 2 cardiac failure. Because pre-operatively, I didn't take an echo. So when I discussed the cardiologist, he said that if you had done this echo pre-op result, definitely there will be some amount of symptoms as well. So that was the only lucky thing was it was the first case and patient recovered. So from then onwards, irrespective of the age group, pre-operative workup, we go for cardiac evaluation and even post-op, irrespective of whether the surgery has come out good or not, we expect some complication or not. These are the protocols which I follow. Anything to add, sir?
The opioids and sedative things you don't use for the post-op period.
Patch, the cancer.
Even then, sometimes can produce sedation. So immediate post-op, first 1 day we don't use that.
So last 2 questions. Yes, Dr. James previously mentioned that. So what's the surgery result for a person choosing sleep surgery? So what is the surgery conversion percentage he should have? What is the expectations level?
So if you have done maybe 5 to 10%, in the initial period maybe even less, but they may get discuss everything with you and then finally get it done somewhere else. So the initial conversion rate will be 5 to 10%. Slowly it will increase once you start getting referral patients or patients.
It depends upon how you are practicing.
Okay.
Any ENT walk-ins you try to convert them as an OSA patient, they might undergo the sleep study and it will stop with that. If you are picking up real OSA patients, it will be about 20%.
One of the main side, one take-home point should be that we should be open-minded to suggest them non-surgical management as well. In fact, we should offer CPAP for everyone. On CPAP, there is 70% CPAP trial where we can ask the patient to have a trial of CPAP for 15 days or 30 days. At the end of 30 days, we get a CPAP trial report. In that, as Dr. Vijaya said, there will be pressure levels will be there. AHI can compare. And at the end of 15 days or 1 month, the patient will have an idea whether he or she will be able to use the CPAP for a longer run. So based on these conclusions, we can go for the next step.
surgeons I would compare and say it's like autosclerosis. We are not doing surgery for all the patients with autosclerosis, and we extend the patient, give them an option, use hearing aid or stereotomy. And there is patients wish whether to get a surgery or not to use hearing aids.
So, last question.
Actually, this is worse than status because status surgery and the hearing aid gives equally good results. So, ideal patient for hysterectomy is the ideal case for hearing aid. But the problem with this is that gold standard is CPAP only. So, first thing usually CPAP. And the patient says no, then only everything else.
So it's actually the last question. As I said, it's an evolving field. I can remember, I think 7, 8 years back during one of the conferences, I think Dr. Vikas Agarwal was saying that what we thought it would work in 2005, nowadays we are starting to get recurrence. So, your thoughts, final thoughts about that recurrence?
See, when you are in the beginning, when you are telling the patient, don't give them that 100% it won't come back. You have to tell them there may be possibility that it can have a persistent or minimal snoring even after the surgery, but that is not going to affect your health. So that you also should have convinced yourself. Otherwise, you may think, okay, what is this surgery? Patients are coming back, and it is like we are doing this for a sinusoidal polyposis. So patient may come back with again and again with polyps. So you have to prepare yourself to mind that it's not going to work, but the patient's quality of life will definitely improve. So the recurrence rate, I would say, is depends upon what surgery. There are so many factors here, but on an average, you can get about 70% good result if you are choosing the right patient. If you are doing the best of your ability and the very right patient, you may even get 90% result. I would say not, I would say 100%.
So, in my personal experience, if a patient comes with you for predominantly OSA symptoms, he will be much happier post surgery. But if the patient says it comes only for snoring, then we should be very cautious.
That's what. So the different why he has come. If the patient is coming mainly because of daytime sleepiness, and his sleep hygiene is poor along with snoring, and if you have treated snoring, if the sleep hygiene is still poor, he may be still having daytime sleepiness. So you have to see, that's where the entire history is also very important when you are looking at failures and revisions. Yesterday we had a
So, that comes to the end of the session. So, thank you, sir. We'll all break for lunch. The next session will start sharply at 2 p.m.
Got a doubt. So I'm an orthodontist working in Government College Hospital, sir. I would like to ask you, sir, we are doing some mouth breathing appliances. That is, patients start with the mouth breathing habit. Each and every patient of mouth breathing will be having obstructive sleep apnea, or it's like random?
Various reasons are there. So, the snoring comes because of obstruction or because of non-obstruction. If there is a, we call it as a box content theory. The box is the bony structure, and to an extent, the septal deviations and canal tonsils. If these are all the problem, this got to be can be characterized with your appliance. The problem is soft tissue. When these appliances won't work much.
yes, as he said, when there is a vacuum back there, and when we can't approach it properly, you may open pipe and all those things, then automatically the mouth will be open position when the child is sleeping, not only sleeping, even while awake. So in that scenario, before doing any work on that, just get an ENT opinion to make sure the airway is clear.
One more thing, sir, like we do mandibular advancements also. Like patients usually turn up with some cosmetic reasons, like my lower jaw is looking small and kind of things. But they don't exactly tell about the breathing patterns or some ENT problems or something. But cases may differ, right? Like each case we do with mandibular advancement, will it help out with the airway also? The soft tissue shape will change according to the mandibular advancement.
Ultimate treatment for OSA is maximum mandibular advancement. The problem is it produces more mobility. That is the problem.
So this cost is small. I mean to say, like mandibular advancement appliance, we promote it like an anti-snoring appliance sometimes. That is, we advance the mandible, simple in design. They use it only in neck. The mandible is going advanced. If it is solving the problem, will it be a fruitful one, or we have to definitely refer and get up all the things done?
This is like I go for a job here or I go for job in US. Job in US is allocated. So, but the thing is, when you have a small skills like you can completely solve this problem or unrealistically solve this problem. Only once you go for an actually advancement or a if at all we go in adult, there is a fixed array and there is a fallback of tongue. We go for only GDY advancement. Of course, this patient also will do well with the mandibular advancement. That's a overkill.
Okay, so then it goes by cosmetic as well as functional.
Yes.
Thank you, sir.
When you have a functional problem, there will be a cosmetic problem, but it's not available.
Thank you, sir.